Good morning and welcome to you all watching us on YouTube. This is Samir Mehta. I am the course director of Lumen Global in its 19th year. Today is February the 3rd and we are all assembled in Jaipur, India. Looking forward to 2 days of an exhilarating STEMI meeting in which we'll do our best with this amazing faculty to make absolutely pragmatic recommendations how STEMI interventions could be improved in India and in the ASEAN region. We also have attendees from other parts of the world and hopefully they'll be able to take profound messages and make difference in a most pragmatic way in their own countries. Now, this interview, we do it ahead of the formal meeting each year, and I'll begin by introducing the wonderful Lumen Foundation and the Lumen Global faculty. Starting on my extreme right is Dr. Christopher Granger from Duke. Christopher, good morning. This is possibly the 6th or the 7th meeting you're attending, and Dr. Granger is also the recipient of the Lumen Global Achievement Award, I think, 2 years ago. Welcome, Christopher.
Thank you, Samir.
Next to him is Dr. Holger Thiele, who's going to be sharing with us a lot of new information about the most recent dramatic changes which have occurred with the management of cardiogenic shock. Dr. Thiele comes to us from Leipzig, Germany. Good morning, Holger. The world's biggest expert in telemedicine, the person who has guided me in understanding the magnificent application of telemedicine, and my partner with the Latin program coming to us from Uberlândia, Brazil, is Dr. Roberto Botelho. Roberto, good morning. Pleasure having you here.
Morning, Samir. My pleasure too.
So that everybody understands that to perform a STEMI interventions is not only the job of a cardiologist or an interventional cardiologist. This is all teamwork. No greater person in this team could be more important than an emergency room expert joining us in 2018, and the 2018 Lumen Achievement Award recipient is Dr. Ivan Rokas. Ivan, good morning. I personally do not know of a single individual who has made more difference in the efficiencies of ambulance and pre-hospital management than Ivan Rokas, and it's an absolute pleasure. So far as I'm concerned, it is his recognition, his training, his message which can possibly make the biggest difference in India. Joining us also on my immediate right is Singapore's Dr. Tan Hui Chim, a personal friend for almost a decade, and there are many, many important lessons he transmits with his AICT meeting, and Dr. Hui Chim will be delivering to us all the elegance which he's been transmitting over the last decade. Hui Chim, welcome to Lumen Global. On my immediate left is the past president of the Cardiology Society of India and a very dear friend, Dr. Shirish Hiramath, who will be taking my first series of questions so that we put on the table exactly the issues confronting STEMI interventions in India. Shirish, good morning and thank you so much for joining. Just to let you know, he arrived here 2 hours ago.
Good morning, Samir. Thank you for the introduction.
On my left, still waiting for his luggage from Canada, is Dr. Michel Limay. Michel, this is why you were awarded the Lumen Achievement Award recipient. You are amazing. A lesser mortal would have crashed not having his bags and going through what he has been through. But here joining us is Dr. Michel Limay, who has transformed STEMI interventions with his most profound work performed in Ottawa, Canada. Michel, good morning.
Good morning, Samir.
The last person on the extreme left, the tremendous mountaineer who's climbed every peak on every continent, is our world's global expert on wrist access, on various aspects of thrombectomy. I'll be seeking a lot of his guidance in the STEMI procedure also. This is Dr. Sasko Kedev, the former president of the Cardiology Society of Macedonia. Sasko, good morning.
Good morning. Thank you very much, Samir.
So with this fine faculty, let us try to see what practical messages we can transmit, particularly to India, a behemoth country with its special challenges. Shirish, take us through what are the issues related with AMI management in India.
I think the biggest problem we have is Indians get it really young. We know that 50% of the cardiovascular deaths in India are below the age of 70 years. And we have coronary disease coming up 10 years younger in this Indian people. So we have to think differently when we talk of these Indian patients presenting to you. They are the bread earners at the peak of their career. So we have to set them back, not just set them back, but send them back in a very good shape. The mortality is also clearly much higher. I think if I see the correct figures, 273 in 1,000 against European standard of about 235 in 1,000 cases. So I guess it has something to do with the timing of presentation. They come late, and once they come late, you're already on the downside of the curve. The ventricle is giving you trouble. Getting the thrombus out also is a big problem. So on a whole, Indian physician has to pass through a lot of difficulties making the patient family understand the issue and the best way to manage these coronary cases.
Absolutely, so many challenges. There are two additional observations I have, which I think constrain the Indian system, besides all the elegant issues which you have articulated. Two issues which I want a better feel from you, Shirish. What about the situation with the ambulance and the situation with insurance?
Insurance is getting better. I think over 40% city population is covered by insurance these days. So as the patient arrives, many of them are these days ready, saying that yes, I have an insurance. So that's a good change. Because I think finance is a big restraint when we offer them PCI as they present. But at least these 40-50% population is getting covered. In India, we have a lot of these IT sector, and many IT individuals, not only for themselves but for their parents too, are covered with insurance. So that's clearly getting better, Samir. The second point is ambulances. Ambulance service, the connectivity is still very, very poor, I would imagine. Most of them, they arrive the hospital in private vehicles or even auto rickshaws. So that's something where, as you said, just as an intervention is important, even the ambulance driver or the person who carries the stretcher also becomes very important, but it's not happening as yet.
Shirish, we are beginning to get a much better understanding, and of course over the next 2 days we'll be discussing these issues a lot. Now, you are the immediate president of the Cardiology Society of India. What did the society, or what all is the society doing to improve the situation?
The society is very active. In fact, we have many subspecialties. We in fact came out with Indian guidelines for STEMI management last year. So this is published so that a physician by and large can have a pocket guideline how to manage the acute case. Also, there's a detailed booklet which is available to them. The society has taken great pains to spread it across the country. So we have actually reached these booklets to physicians' desk through a connectivity network. So I'm sure these are very specifically thought over guidelines for the Indian scenario. They have taken into care the Indian mindset, which generally is a denial of illness. Then how we can save time before they get to the hospital, and which hospital to go to, so that either they get lysis or they move in a faster track towards primary angioplasty. So we are sort of encouraging physicians to have a correct path prefixed in their mind, so that once they have a STEMI patient in front of them, which is the fastest approach to save time.
Shirish, how is the message of the Cardiology Society of India? How is that, what is the pathway, how is it going, not to the cardiologist, but to the general practitioners, the GP?
Yes, I think the society has in different states their sort of subheads, and we are spread into something like 53 cities in which the Cardiological Society has its something like a branch offices. These are big in their own way, so they keep conducting various courses. Most of the societies do one a month, a meeting. And I'm sure at least 50% of these meetings will have STEMI as the main foothold on which the meeting is built. So this way we are creating ripples so that we reach the physician, including the emergency physician, to understand the quickness of management.
Absolutely fantastic, Shirish. One more series of questions, and I'm deliberately asking you all this so that we have a very good understanding and a foundation how to work on the specific issues. Tell me, Shirish, what in 2018, what percentage of patients in the country are getting thrombolysis, pharmacoinvasive management, and primary PCI? Just an approximation.
I think majority are not getting any treatment. That's a bad scene. Having said that, we are clearly getting better and better. The figure was just around 20% 5 years back. Today it's improved, and about 50 to 55% would either get lysis or they would get primary angioplasty. Amongst these 50, 10 would get primary angioplasty, and the remaining 40 would get lysis. But most of the patients who go get lysis, they would come back to cath lab for an angioplasty a day later or 2 days later as a invasive management. So this way, I think a bigger and bigger sector of STEMI is getting covered with some kind of therapy, be it primary angioplasty or pharmacoinvasive approach. Amongst the total PCI that India does, about 17% are primary angioplasties. So I think that number is also clearly getting bigger, indicating that we are able to approach a higher percentage of STEMI through cath lab.
And a lot more PCI institutions are able to offer 24/7 primary PCI?
I would imagine in the metros and bigger cities this is happening. As you move away, these are cath labs which are run by solo operators. I think there you would probably struggle to have 24/7. So for them, lysis becomes a very important option, and the cardiologist would probably gather all his staff next morning and do the case.
Shirish, several members of this faculty have been previously attending the meetings in India. I'll get their individual viewpoint, but I can tell you personally from my vantage point, I already sense profound improvement. There is a great enthusiasm, and I compliment you as the leader of the Cardiology Society of India for having articulated several of these changes. Let's try to now get a feel of how can we make things better. I'm going to start off with Dr. Granger on the extreme right, because Dr. Granger, just for people who have not been familiar with his work, almost 12 or 14 years ago, maybe even a little earlier, he networked the entire state of North Carolina in the RACE program, and more recently he has been extremely active with the American Heart Association creating what is known as the STEMI Accelerator Program, how these programs go into deep into a community, into a city, and try to offer recommendations, how the stakeholders are increased. Chris, provided this situation, and I'm sure you are recognizing the improvement as I mentioned, what do you think would be some of the lessons you could offer to Indian physicians, Indian societies, and to our audience at Lumen Global, how interventions, primary PCI, could be improved in India further?
Well, thanks, Samir, and I think you've already outlined some of those, and it some of it begins with what you've done in Lumen Global, and I think we like to talk about this not as a program but as a movement, and if we get committed leadership, professional societies are critically important. We found that in the U.S. to give credibility in a independent group to really promote this on a broad scale, including public policy, but also clinical leadership. People at this table and the people you're bringing together from Asia and India at this meeting, and who are really committed to solving the problem, recognizing that coronary heart disease is the #1 cause of death in India, that acute MI is the acute manifestation, and the most important way by far to save lives is consistent early reperfusion, and that can be with fibrinolytic therapy. I think we're getting better and better evidence that pharmacoinvasive is a really good treatment, and it will continue to be, I think, for much of India. But primary PCI is the best one we can do it. We'll also, for example, get the TREAT trial results in a few weeks at the American College of Cardiology, which will define whether ticagrelor is another tool with fibrinolytic therapy and with the pharmacoinvasive strategy. I think that'll be a very important result for India. But the fundamental issue, I think, for what can be done now in India is to use these examples where different regions in India have actually been very successful, some in Kerala, some in Rajasthan, some in Delhi, where groups of hospitals have been very successful, where emergency medical services now are engaged, where the insurance issue has been dealt with, and to use those as examples for other people around India to get together to make sure that we have data collection and feedback. Ivan is big on this right now and is really helping us even in the U.S. How can we be more efficient in how we collect data to feed it back to our individual hospitals and EMS services to make sure we know how we're doing and to continue to improve?
Chris, two further follow-up questions on what you have described. Can the STEMI Accelerator Program be applied to regions of India? That's number one. I'll actually let you answer that first. And then the second follow-up is, how do you encourage stakeholder creation in STEMI initiatives?
So the answer is absolutely it can be, but and you've already outlined this nicely. The principles are the same, but the barriers and the solutions are different. They have to be worked out by the local environment, by the people who are the participants in that region. And I think that's true even in separate regions in India. There isn't one solution for India. India is a big country. So, but I think the principles that have been laid out and all the information is available. The specific protocols that are suggested for how EMS, which patient should get a pre-hospital EKG, how can it be communicated to the PCI center, and obviously Roberto and the telemedicine plays a role here. But those things from the STEMI Accelerator program can definitely be applied. How do you bring together stakeholders? I think it's what you're doing at this meeting. It has to include interventional cardiologists, general cardiologists, emergency medical services leaders, hospital and policy leaders, primary care, as you suggest, I think is another important group.
Fantastic, Chris. We'll continue to engage with several of these specific issues in the meeting today and tomorrow. Ivan, this should be as fertile arena for you. with so little penetration of pre-hospital work. Share with us some of your solutions on how to improve the pre-hospital, the ambulance, and the various other process factors.
Absolutely, and I want to echo some of the comments Dr. Hirmoth made about pathways. Patients will do whatever they do for a variety of reasons, and no matter how they enter or access or interact with the system, we need to have a pathway to identify who is a true STEMI. Out of the every 100 or so chest pain patients, maybe 4 or 5 have STEMI, and then how do we rapidly get them to the front door of a cath lab? And that's really the big challenge. Going back a step further, once we get the system up and running, the patient remains a challenge because Dr. Hirmoth mentioned denial. Well, I think that's a universal human feature. And patients often deny their symptoms and don't present early enough, and or they present to a general practitioner. And empowering that general practitioner to identify a STEMI is, I think, key. I think, honestly, the way for India to move forward is technology. And I've been talking about this before. It's in our pockets. It's our smartphone. I think that is really the key to making everyone more efficient. The other issue, of course, is ambulances. That's a harder question. That takes money, government, and that I don't have an easy answer for, but that clearly is important. But not just, you mentioned the word, not just ambulances that drive, but intelligent ambulances. They need to be able to identify a STEMI patient and add value to those patients.
Excellent. Michelle, there are similarities in some ways. Just the size of the country, Canada, a very large country, India, of course, the population being so dramatically different. Some of the work which you have done, how could it be applied to improve the situation in India?
Well, Canada is a very large country with a very big geography to deal with, and so we have the issues of weather, winter. So the snow is an issue, and then distance is an issue. So I think you have to sort of figure out what's in your own backyard and what are the issues, and try to apply the basic principles. Chris Granger talked a little bit about this, that there are some basic principles, and I think the first principle is that the recognition that you may be having a heart attack. This is at the level of the population, and I think there's a big educational component that needs to be done there. And I think Sharissa has already highlighted the efforts that are made by the colleges of cardiology in India to try to educate the population to go out there, to get them to notify the medical system one way or the other. They may not have an ambulance, so the alternative may be to show up at a clinic or show up at a hospital, but to show up, because if you don't show up and you're 12 hours, 16 hours into an infarct, it's pretty hard to bring in the PCI team, to call the ambulance, to do all that work. It's kind of game over in some ways. So I think that's the number one priority, is at the level of the population to get the education out there. Then I think that you need to apply the same logical principles in terms of once the first medical contact is made, whether it be at a hospital or whether it be in an ambulance, if an ambulance is available, the principle is still time. There isn't anything more powerful to treat a myocardial infarction than to get the artery open in a timely fashion. We can talk about aspiration catheters, we can talk about all kinds of devices we have in the cath lab, different anticoagulants and all that, but at the end of the day, it's all about getting the patient reperfusion therapy. And the choice of that reperfusion therapy is dictated by what's available. If it's streptokinase, let it be it. If it's TNK and you have it, that's great. And if it's primary PCI, all the better. But I think that you have to get some reperfusion therapy. And I understand you were saying, Sharish, that as much as 50-55% of the patients are not getting reperfusion therapy. So streptokinase is much better than no reperfusion therapy. So if there is a choice to be made, it's got to be getting some form of reperfusion therapy. The rest of the pieces of the puzzle will fall into place as you start getting out there and getting some form of reperfusion therapy and getting the public education, and that can start at all levels. It can start on a public awareness. It can programs, television, newspapers. It can start at the level of the high schools. It can be television, and it can be CMEs at the level of doctors. So I think awareness is very, very important.
All very elegant suggestions. I'm sure several of these can benefit and improve the situation in India. Let's move over and see if there is another solution, something like what Dr. Rokas mentioned about technology, and I am talking about telemedicine. Roberto, can telemedicine transform STEMI care in India?
Definitely, yes, Samir, definitely, because telemedicine can contribute to all the questions pointed from the previous colleagues. Number one, awareness. Telemedicine is a powerful tool to provide awareness. Number two, that Chris pointed very well, the problems are the same, but the solution must be customized. By using telemedicine, you may customize to every different areas as we are doing in Latin America. And I would summarize that by using telemedicine, you may, number one, access access capillarity to remote areas. Number two, scale. You get scalability, and by cloud computing, you can share top cardiologists with the most remote areas that lacks physicians at all. And number three, technology, artificial intelligence, that may play a very important role. And at the end of the day, you notice that the diagnosis of STEMI is very, very, very simple. A few variables. If you put those variables in a computer system, they can easily give you the answer. And the best way to share with all of you the impact of telemedicine for India, I would share our figures. 1 year ago, we came here in Rajasthan, and I presented 170,000 patients screened in the Latin program that you created. This year, I'll share with you 517,000 patients, 500. And 1.2% were STEMI. Then we expanded the screening program. Ivan just mentioned that we expect 40% STEMI from the chest pain patients. We got 2%. Then we expanded the screening program. And we completely changed mortality. In Mexico, Colombia, and Peru, average mortality was around 20%. 20%. And it moved back, it moved down to 80%. Wherever we implemented, even from Colombia, Mexico, the most remote areas of Brazil, the figures were just the same. And the best way to answer is to present the figures. More than 50% mortality reduction and cost effectiveness. To start any program, the number one message is it must be cost effective. In the city of São Paulo, I can mention the Santa Marcelina experience. It's a large public hospital that saved $500,000 per year. They saved avoiding thrombolytics, and the number of the percentage of lytics came down to 8% because they offered direct primary angioplasty transfer. Then these are the main figures that may help India to, number one, customize, number two, scale, and number three, to offer capillarity through the most remote areas.
Very nicely articulated, Roberto, and there are several telemedicine sessions at the meeting where we'll try to go deeper into some of these issues. Now, when I assembled this faculty and we are trying to provide solutions to India, a person who has a great feel of not India but the region is Dr. Tan Hue Chim. Hue Chim, you have observed several of these challenges in the countries represented with the AICT. What are some of the solutions that come to your mind? And also, I want to take this further. You have been very responsible in looking at some quality initiatives, knocking out very strongly, getting away from the door to balloon time mindset and moving on to the symptom to balloon. Share with us some thoughts. Again, a two-part question. solutions which come to your mind about India, and secondly, the quality initiatives.
So, Samir, what I have observed over the years in terms of dealing with my fellow colleagues from Southeast Asian country is that different countries in our regions are at different stage of development of the STEMI network and services. However, there are considerable progress and courage being made to try to actually improve this care to patients. And I feel that most of the countries do have a common recognition of what the benchmark excellence is all about. People are concerned with the time of care delivery, door-to-balloon time, outcomes in terms of mortality and so forth. So I think there are still progress and changes and improvement that need to be made, much of which has been touched on upon. I feel that leadership is the key fundamental to success of a program like that, and leadership in terms of medical institution level, professional society, state, as well as the government level to push this program. But I'm actually quite optimistic given the sort of people that I'm working with in the region. Singapore don't have the proximity issue of the geographic expanse of many of the countries that I'm hearing today. And so in some way we are actually blessed by a fairly mature STEMI network system with fairly optimized system as well as processes that has been put in place. We have been talking about qualities in terms of door-to-balloon time and in terms of outcomes, which are still important, but I feel that now we need to take it one step further and talk about value. We want to talk about value-driven outcomes instead of just pure quality indicator. And by value-driven outcomes, I mean we want to talk about how to improve quality with cost rationalizations, knowing that healthcare cost escalation is really a problem that we all grapple with. And we also want to minimize whatever sort of variation in practice to try to achieve a consistent value outcome. And I think this is really the way to go in future for STEMI care, that we are able to drive down the cost while maintaining a high quality of care for a patient.
Look, those are very exciting proposals. Shirish, some thoughts about what we have been proposing? In fact, I want you to hold on for just a moment. I'll come to you. Before that, Sasko, you've been involved with various aspects, not only in Macedonia, but also with ESC. What are some of the suggestions which come to your mind?
So access site is becoming very much important because we have a very strong evidence of even mortality benefit associated with radial access when we compare it to a traditional femoral access. And it is now very difficult to justify femoral procedure in STEMI, at least in Europe, because according to the latest last year ESC recommendation, radial access is class 1 level of evidence A recommendation for STEMI, because we have a clear mortality benefit associated with the radial access. I can see it now, it's one of the single most important difference between European and American approach. We are looking forward to see how American approach will be, recommendations will evolve, at least according to the latest data we have available. We are waiting for some other important trials in the field, but according at least to a metrics trial and according to a largest UK and Scandinavian registries, we have very clear recommendation about radial access.
So, take me further from radial to wrist access, because what I have known about your work, you are also a very big proponent of the ulnar access. What is the data there? What is the progress being made? And what is your personal recommendation and approach?
So definitely ulnar is considered as alternative to a radial. It's not a primary wrist access because ulnar is a pretty large artery, sometimes even larger than a radial. There are not so many anatomical variations in comparison to a radial, but definitely it's alternative. What alternative means? It means access first crossover alternative to a radial. At least in our practice we have more than 1,000 patients with ulnar access with occluded radial, ipsilateral ulnar, no single case with a hand ischemia. Definitely it seems it's very safe to proceed to alternative ipsilateral ulnar to crossover instead of femoral access. That's the best way to decrease rate of bleeding avascular complication.
Excellent. Shirish, so many experts have provided their suggestions, recommendations. Do any or most of them appeal to you?
Oh, very certainly. I mean, it goes without saying that we should have approach at various level. In India, we have issues about education, understanding the mindset, and of course the reach from bigger cities to somebody who is living in a very remote area. All these factors need to be sort of netted in, and the best way is to communicate with them. And I guess the smartphone could be a key to many issues. The smartphone in India is sort of getting compulsory, and that's a good news because people are now getting so dependent for living, day-to-day living on smartphones. So I'm sure this kind of connectivity would go a long way in getting to the patient. Once a patient-doctor contact is made, I think things are much easier in India. In India, I have seen lysis being given within 10 minutes after the onset of pain because patient has a direct access to doctors in a majority of the places. So there is no ambulance service, there is no intermediate emergency care paramedics. It's a direct. So the doctor is in a very strong position to make decisions about lysis. So yes, there are things already available. We need to make use of these.
Excellent, Shirish. We are making progress. We understand the issues in India. We propose a series of solutions, and we'll take them forward with some recommendations coming out of Lumen Global. With such a fantastic faculty, I want to now go deeper into the STEMI procedure, and there is no bigger challenge to an interventional cardiologist, and I think that becomes even more relevant in India because of delayed presentations and patients going into cardiogenic shock. Nobody, at least amongst in the last decade or so, has done more work on the topic than Dr. Holger Thiele. Holger, I compliment you. You've done such amazing work to have performed trials in something where most of the trials in shock have been just given up because of the lack of getting enough patients through the system. Two specific areas, and take us through each of them in as much detail as you want to. Your recommendations coming out regarding the treatment of the culprit lesion only for cardiogenic shock, which has such amazing implications of what we do each day. And secondly, talk to us about the use of mechanical support for these patients.
Yeah, first of all, when we talk about patient with cardiogenic shock, we know that approximately 80% of these patients present with multivessel coronary artery disease, which is a major challenge for us when we get these patients to the cath lab, because until recently we did not know on how to treat these patients. So the guidelines gave the recommendation that we should go for immediate multivessel PCI in these patients, which was mainly based on pathophysiologic considerations. So these pathophysiologic considerations were that we improve the perfusion of these patients if we also treat the other lesions in addition to the culprit lesion as well. So maybe this is what we believe, that we will have better recovery of the left ventricular function. However, all these guideline recommendations were based on They were class C recommendation because there was nearly no evidence. And if you look into the registry trials, so all the registry, or nearly all registry trials have shown that there is an increased mortality if you are doing immediate multivessel PCI. Problem with all these registries, like always, is that they are prone to bias. And that's the reason why we set up the so far largest randomized trial in cardiogenic shocks, the so-called carpet shock trial. And in the end, we could show that carpet lesion-only PCI is largely superior to what the guidelines currently recommend to do immediate multivessel PCI. And we were surprised to see an absolute 8% reduction in mortality at 30 days by just doing carpet lesion-only PCI. So I think this is for me, this was a big surprise to see such a huge difference in mortality. So now if we are talking about these patients, and this is probably the biggest challenge what we currently have, if we see these patients with cardiogenic shock, so the major message from our trial is now do it as simple as possible. Just reopen the infarct-related artery and don't take care of the other lesions. You can take care of the other lesions later on. So you can do it as a staged procedure when the patient has been stabilized, and then you can do some ischemia testing, or maybe also based on the anatomy. When you have a high-grade proximal additional LAD lesion, then you can consider doing PCI on this. With respect to the second topic, this is maybe the open question nowadays. We all believe that by putting mechanical circulatory support in, that we can reduce mortality. However, this has not been proven so far. We need more data on this. We all believe it, in particular you in the United States believe that you have to put it in every patient and as early as possible. I'm not 100% sure on this. So we have shown that in a randomized trial that the intra-aortic balloon pump has no effect on mortality, which is also maybe important. So now this is a typical reflex what we all have. So we have seen that the intra-aortic balloon pump does not work. So now we are moving a step forward. So we go to active devices. I think we still need the evidence. For sure, we are also using it in the most severe patients, the patient with most severe cardiogenic shock. However, we still have to decide, and this is what we currently do. This is more a gut feeling when we decide to go for an ECMO or maybe an impeller or maybe other devices. We need much more data on the real selection of these patients who really have a benefit from active mechanical circulatory support. This is probably the next thing what we have to do in the maybe next 5 years, on looking for the best data and the best patient selection on when to use active mechanical circulatory support.
You are also proceeding with several additional trials with some of these devices?
Yes, we currently try to get funding on doing a large-scale randomized trial with active mechanical circulatory support. There are other initiatives trying to do it. I think this is crucial to get the next answer on how to deal with cardiogenic shock. I hope that these trials will be positive. I also hope that the intra-aortic balloon pump trial would have been positive, but in the end we have shown that this device does not work. But I hope that we will have any tool for a reduction of mortality in patients with cardiogenic shock. When you're looking back to the 1999 publication of the shock trial done by Judy Hochman, the mortality was 45%. Now, nearly 20 years later, with carpet shock, we now still have a mortality of 45%. And this is something we have made no real progress in the reduction of patients with cardiogenic shock.
So far as, let's say, getting you involved in the discussion regarding challenges in India, it appears that getting the patients, eliminating the delayed presentation and getting them earlier would also be getting you more patients who have still not been in shock?
I think, yes, this has been shown in many registries. So if you're doing more and earlier reperfusion, you reduce the mortality, but the mortality is probably mainly reduced because you have less cardiogenic shock. And this is very important. So if you do more reperfusion, you have less cardiogenic shock. And this is probably the most important issue.
Chris, we have evidence enough to modify the guidelines regarding cardiogenic shock?
Well, absolutely, with respect to the culprit artery, I think, but Holger's points, I think, are right on about the lack of evidence around mechanical support, and we really don't know what to do. Bill O'Neill in Detroit has a program where he's systematically placing impellas very early, as early as possible, who are have evidence of cardiogenic shock. But we're just not certain what the best approach is going to be. So I think there we need more evidence.
What about just primary PCI and addressing the culprit lesion only?
I think that's what we have evidence for. And I think Holger is clearly the world's expert in this area and has done more than anybody. And he'll give us he'll update us on the details of other elements, which I think are very important for India, which inotropes to use, what other aspects, avoiding beta blockers in people who are have heart failure that might put them into shock. There's some other practical recommendations that I think are very important.
Michelle, a STEMI patient, no shock, culprit lesion only?
We tend to do culprit lesion only. I think at this time the trials that have shown that there may be some benefit are relatively small. We're waiting for the results of the complete trial, which is a larger trial, to help us decide whether or not how much extensive revascularization that we should do. So in a big program, when you're really busy and you got one that you're already doing and now you tackle another lesion and suddenly got one in the back room that's waiting to get in, I think it's not always helpful to tackle a second lesion.
What is your rationale and feeling for circulatory support for cardiogenic shock in Canada?
I think that there has been a slow adoption of the results of the intra-aortic balloon trial. I think that people tend to stick to old habits, and I think that the one thing that I like to do when I have a patient that is in shock is to get a quick assessment of the ventricular function, and we use pocket echo a lot. I think maybe there are still some subsets that benefit, like mitral regurgitation, but in general there's been a pullback. We don't do as many, but I can tell you there's still some peer pressure to do them. And you turn to your resident, and the resident say, well, why don't we put a balloon in? And you look at the back of the room when the patient's intubated, and the anesthetist is saying, well, we usually put a balloon in that patient. So it's going to take a while to turn the page on this one. I don't think it's going to happen overnight.
Hui Chim, circulatory support in Asia?
Well, I think intra-aortic balloon pump is still the mainstay for most of the countries, but I do agree that in patient who is in full-blown cardiogenic shock, IABP is not going to work. I think IABP is going to work very well in the pre-shock state, so the challenge is really to identify these patients. What we are also moving forward is the use of an impeller device, but certainly not the impeller 2.5, which again I don't think the evidence support. So we are thinking of starting an impeller 5.0 in Asia, with Singapore as a reference center, working with the industry to push for it. But from a theoretical standpoint, I would imagine a combination of ECMO to improve the oxygenation level, plus a active afterload reductor such as impeller will make the most sense as far as the patients with cardiogenic shock goes. But that will mean tremendous costs of treatment for patients like this. So we are probably going to be very selective in our patients who are going to be put on this mechanical circulatory support, certainly only for the young patients of under age of 60 years old.
Shirish, circulatory support status in India?
I think the aortic balloon pump still remains mainstay. In majority of the labs, that's the way to go. The ECMO is available across the country. And it is used for non-cardiac reasons more often than cardiac reasons. So I think it is possible that in months to come we'll see more of the other supports coming in ahead of IABP.
Impella available in India?
Yes, that too is available.
Changing topics further, Michelle, on to you. What is the situation with out-of-hospital cardiac arrest, the role of hypothermia?
Well, we've developed a center for cardiac arrest in the Ottawa region in Canada, where we now identify all the patients who have a shockable rhythm to be transferred to our center. We still are in the mode of doing coronary angiography at the same time that we do target temperature management. We believe that at this time the point estimate is in favor of doing that, and I think that there will need to be some research to tell us that that is not necessarily the case. For sure, there's about 40-45% of patients that presents with a shockable rhythm that have STEMIs, and so they need to go to the cath lab regardless. There's a small subset of these patients that have shockable rhythms that the electrocardiogram at the time of the cardiac arrest does not reveal the true pattern of a STEMI. And these patients turn out to have what appears to be a STEMI in terms of thrombus and an ulcerated plaque. Then there are some that simply have a lesion that can be dilated. As to whether or not it is the right thing to do to dilate that lesion. If we find what we think may be a culprit vessel, we'll dilate that lesion. And then the principle is that when you're in the cath lab, you are managing the patient as a team. You're already sending out the blood gas, doing the electrolytes, putting in a endovascular cooling device, doing the angiogram, doing the diagnosing, and managing the patient like you were, as if you were in the emergency room itself or in the critical care unit. So that when you have all of your team that is at that time at the attention of that patient. And I think that in its own may make an impact.
Excellent. SASCO, access for patients with cardiogenic shock.
So for a primary PCI procedure, radial could be done in most of the cases, and we keep femoral for a vascular access for LV support. It's a routine standard of practice.
Excellent. We're going to begin concluding this session, but before I go through that, Chris, final best 3 recommendations for India.
Well, I think, again, identifying best practices. I think there are some really successful programs that have occurred, and I think highlighting those, going to other, identifying other leaders in areas outside of those regions and leveraging those successes, I think will be really important. Collecting data, I think, is also really important to measure what's happening, to assure that there are continued increases in the proportions of patients being treated with some reperfusion therapy, and then after that reperfusion therapy, getting them to the best center to make sure that they have complete care, that's the optimal care. And then, as we've talked about, I think the other issue that's so critical is to get patients to come in sooner after their symptom onset. And we in the United States have seen that happen when we put systems in place, especially in urban areas. And I'm not sure exactly why, but I'd be hopeful the same thing would happen in India, that this type of work, including some public health efforts, will result in people coming in earlier in their symptom onset when more lives can be saved.
Excellent. We will conclude the session right here. Once again, this was the pre-Lumen Global YouTube interview. I hope you found it useful. My thanks to this wonderful faculty which has joined us this morning, and we'll follow through with more deliberations at the Lumen Global meeting. Thank you.